And it's recording now, so let's get started. Welcome everybody to the first CGHS webinar for the 2017 year. This is the CGHS webinars are hosted by the CGHS's Public Health Department. And today's presentation is going to be given by Lihua, Dr. Lihua Dishman. She's a assistant professor in the College of Graduate Health Studies in the Health Administration Department. And she primarily develops and teaches healthcare financial management, research methods, and capstone courses in both the DHA and the MHA programs, advises and mentors students in both programs, and serves as a chair or member on several DHA dissertation committees. She holds a DBA in management, an MBA in finance, business, economics, and a bachelor in statistics and economics. As a scholar practitioner, she maintains an active research agenda with 5 connective research streams. There are patient experience, healthcare financial management, revenue, which includes revenue cycle management, securitization of receivables, risk management, and hospital financial performance. Also healthcare leadership competencies, exemplary online adult learners, and engaged scholarship. Her research interests are grounded in her worldviews and core values, and the principles of engaged scholarship, which focuses on participative research that links theory to practice. Since joining ATSU's full-time faculty in 2012, she has made 14 peer-reviewed scientific presentations and 11 invited scholarly or professional presentations at international, national, and regional conferences, as well as local research symposia. She serves as a peer reviewer for Patient Experience Journal, Michigan Academician, California Management Review, and Academy of Management, and served as a judge of the Association for Patient Experience to select winners of the AFPE Outstanding Caregiver and Practice of the Year Awards for 2015 and 2016. Furthermore, she serves as a member of the CGHS Faculty Council, several health administration and CGHS committees, and an AOM committee. So welcome, Lihua. I will now get your slides up. And it's all yours, Lihua.
Thank you, Marcia, for that wonderful introduction. Welcome, everyone. On the first slide at the bottom is my email address. If you have any follow-up questions, feel free to email me. Next slide, please. So on this slide in the middle, you will see data collection and data analysis. Since this is a 4-year national study, so data analyses were very, very lengthy. The results were reported in almost 50 tables and number of graphs. So I only include a few here. And once again, if any of you are more interested in more information on data collection and data analyses, send me the email and I'd be happy to share with you more information. Next slide, please. So the study has really grown out of a long-standing personal wish to have a better experience in the hospitals and the doctor's offices. And along the way, a few things also helped affirm my research interest. For example, about 4 years ago, Dr. Kathy Adler, our associate dean, and I co-taught a residential learning institute for our MHA students. Her topic focused on patient-centered care and patient-centered leadership. And during her session, the discussions and the examples emerged, which is fascinating. And so that really helped me look into literature as related to patient-centered care, patient-centered leadership, and then that lead to patient experience. Next slide, please. So from literature, we also found an urgency for this kind of study. For example, the state of population health is not that great. We spend a lot of money in healthcare. However, our outcome ranks low among developed countries. And so in response to our high cost, but low result kind of health, the state of population health, industry leaders responded. And then one of the initiatives was a triple aim, which is improve patient experience, improve population health, and reduce cost of care. Next slide, please. And so we're seeing a transformational shift in reimbursement from volume-based to value-based. The hospital value-based purchasing program is just one example. This program uses a patient experience survey to measure major hospitals' performance. So this survey is called HCAHPS, Hospital Consumer Assessment of Healthcare Providers and Systems. It is very significant because it is the first nationally standardized survey of patients' perception of hospital care. So it is very important because the first nationally standard, and it's also from patient's perspective. Meantime, from financial aspect, the top concern of the U.S. hospital CEOs for over 10 years has been financial challenges. Next slide. So the purpose of this study is to investigate the relationship among three actors. They are patient experience, hospital type, and financial performance. And also to assess whether or not there's a moderating effect of hospital type on the relationship between patient experience and financial performance. So it's a multi-level analysis. Next slide, please. The three constructs of the study are patient experience, financial performance, and a hospital type. Among these three constructs, the patient experience is a latent construct. Next slide, please. So there are two research questions. One is really to take a look at what is the relationship between patient experience and a hospital financial performance. In other words, if hospitals that provide better patient experience can also perform better financially. So that's really the first research question. The second research question is to take a look at what role the hospital type plays as a moderator in the relationship between patient experience and financial performance. Next slide. So let's take a look at first construct, which is patient experience. The patient experience really is a sum of all interactions that a patient has with both clinical and non-clinical staff of a hospital. So, for example, on the top row, the left picture shows you a patient is standing in line and register. So her interaction with staff here is most likely non-clinical. On the right, it's a patient room, and the patient's interaction here is most likely with clinical staff. And could be non-clinical as well, staff who delivers the food, staff who comes to clean up a room, could be non-clinical staff as well. So the patient experience is really sum of all interactions, including interactions with both clinical and non-clinical staff. Next slide, please. Oh, sorry, this is a mistake. I'm very sorry. what you basically look at the first circle, it shows the U.S. hospitals. That's next to 52%. The lower circle actually shows patient experience or patient satisfaction. Basically, what this slide shows you is that patient experience or patient satisfaction remains to be the top concern for 52% U.S. hospitals, but even higher among non-U.S. hospitals. Among 53% of non-U.S. hospitals, patient experience remains top concern. So now you can see the patient experience or patient satisfaction, the concern is a global phenomenon. It's not just in the U.S. Next slide, please. And the patient experience is also in prime time. NBC started a 1-hour drama in 2016 called Heartbeat. And in one episode, this is Dr. Callahan asked Dr. Patel, who is the administrator of the hospital, and he's asking her for a job to become a chief patient experience officer. So patient experience is really entering into our kind of everyday life, so to speak. Next slide, please. Two leading organizations and two leading journals focus on patient experience, the Barrow Institute and the AFP. The AFP is really part of the Cleveland Clinic, and so they do wonderful things. I include some information in case some of you are interested in some of the work the organizations and the journals do. There are many healthcare organizations, particularly the hospitals and medical centers. They actually created a new position. It's called either Patient Experience Director or Chief Patient Experience Officer. So we see people are working on the certification to become leaders in this field. Next slide, please. So how is patient experience measured? The first measure is the HCAHPS that I mentioned, focus on hospital. The second measure is called the CGHS. The CGHS is for clinicians group practices. So since my study focuses on hospitals, so my study uses the first survey, which is the HCAHPS survey. Next slide, please. Now, the HCAHPS survey has 10 measures. And based on these 10 measures that I created 4 dimensions. The first dimension is communication. The second dimension is clinical services. The third is the care environment. And the fourth is perception. In the next slide, in about 2 or 3 slides, I'll explain this a little more. So here, hospital type, that's the second construct. There's 3 different different types of hospitals, and these 3 different types of hospitals is actually kind of classified, organized based on CMS's 13 different types of hospitals. So the for-profit hospitals, their mission primarily is to maximize shareholders' wealth. The non-profit hospitals and government hospitals, their mission kind of similar, is to provide medical service to their community and to maximize their stakeholders' interest. So it's a little bit different. Next slide, please. So the third construct is financial performance. And based on literature review, these 5 indicators were identified. Operating profit margin, non-operating profit margin, cash flow margin, return on assets, and return on equity. Next slide, please. So here is where I messed up again. The first circle is really indicates 1,377 hospitals. So it's a quantitative study, secondary analysis of archival data. Both patient experience and the financial data was self-reported by U.S. hospitals. I use the panel data. So the panel data, you have the cross-sectional data is 1377 U.S. hospitals, and the longitudinal data, because it's a four-year study from 2009 to 2012. The patient experience data was from hospital compared data files. Financial performance data was from the HCRS data files. Both data files are maintained by CMS. And so in terms of data analysis, both descriptive and inferential statistical analysis were performed. Next slide, please. So here you get the overview of the variables and the measures. The patient experience is the IV. The moderating variable is the hospital type, and financial performance is the DV. For the independent variable, there are 4 dimensions. The communication dimension includes nurse communication, doctor communication, staff explains new medicine, and staff given the discharge instructions. And the clinical services, including the help received quickly, pain controlled well, and the care environment includes the room, the beds kept clean, the area quiet at night. And the perception dimension includes the overall hospital rating and whether or not the patient will recommend the hospital. So these are the 4 dimensions that I created based on the 6 composite measures, 2 individual items, and the 2 global items of the HCAHPS. And there's 3 indicators of the hospital type, which are the for-profit, nonprofit, and government. Financial performance includes the 5 indicators: the operating profit margin, nonprofit operating profit margin, cash flow margin, ROA, and ROE. Next slide, please. So 4 hospital demographic characteristic measures were identified. These were hospital type, bed size, number of employees, urban or rural designation. We already know there's 3 different types of hospital, but we also identify 8 different bed sizes, 5 classes of number of employees, and obviously urban rural designation. Next slide, please. So on this slide, you see the data collection. I was fortunate to have access to the data where for the hospital compare, the raw data really starting with all the hospitals that reported to hospital compare the patient experience data. And you will see that's a step 1. And on the financial performance side, there's over 6,000 hospitals that reported financial data. And then the second step in each case, I checked for data completeness. And then the third step is really to check whether or not the hospital reported data for consecutive years. And then the last step, the fourth step, which is the last column, then matched the one data file, the hospital compare data file to HCRS data file, and then come up 1,337 1,337 hospitals. Next slide, please. So here are just some highlights of the demographic analysis. Just wanted to mention that the chi-square test for equality of distribution was performed to make sure these classes for bed sizes and number of employees were statistically significant, which, as you can see, the p-values is, very, very low. They're all less than 0.001. So these classes, these distributions are statistically significant. Next slide, please. So I also want to highlight the reliability and the validity of the patient experience survey. Even though HCAHPS was developed by CMS, I still was interested in finding out whether or not the survey instrument developed by the government is reliable and valid. I also want to see whether or not the 4 dimensions that I developed is reliable and valid. So for reliability tests, I used the Chromebox Alpha, and as you can see, they are all most of them much greater than 0.7, which is the acceptable level, and only just a 2 or 3 is close to 0.7. So if you run up, if I keep 2 decimal places, it will be close to 0.7. But I report all the results in at least 3 decimal places. Now for the validity, because the patient experience is a latent construct, and so the latent construct, the observation is indirect by the indicators. So I used the discriminant validity test, and it's called AVE, average variance extracted. So what I did is I calculated I performed confirmatory factor analysis, and I got factor loading scores, and then used the factor loading scores from CFA to calculate the average variance extracted. And so for the acceptance level for the AVE is a 0.5 or higher. And so as you can see, the AVEs is all much greater than or higher than 0.5. So next slide, please. So in summary, the patient experience survey is reliable and valid. And the 4 dimensions that I created is also valid, reliable. Next slide, please. So I also did some intercorrelation analysis between the IV and the DV. And here are just some highlights. What is very important to note is the cash flow margin and operating profit margin, with consistently statistically significant positive correlation with the patient experience, the overall patient experience measure and the individual measures of patient experience. So in the moderation analysis, I used the CFM and the OPM as a measure of financial performance. So I just want to highlight that. Next slide, please. Oh, thank goodness, the red one showed. So you see the 2 red circles. The top one is for the H1, and the second circle for H2. And so this is also the hypothetical model of my study. On the left is what you see is the 10 measures, and then the 4 dimensions of the patient experience, which again is a latent construct. So in the on the right is the financial performance, is a DV. In the middle is the moderating variable. So in social, in management research, in social science research, and you see more and more studies that includes a 2nd level analysis, could be moderation or mediation, or could be a moderated mediation. So because social events are complex, it's like events that we see in healthcare. So oftentimes one level of analysis is not adequate, and second level analysis is called for. Next slide, please. So the study answered research question 1. In summary, the patient experience of hospital care has a positive effect on financial performance. In general, hospitals provide a better patient experience, also performed better financially. Next slide, please. And the study also answered the second research question. It is very interesting that the hospital type made a difference, impact the relationship between patient experience and financial performance. So, for example, for-profit hospitals performed better. So when for-profit hospitals provide a better patient experience, their financial performance performed even better. So it's even more significant. And the government hospital type had greatest moderating effect on the relationship between patient experience and the financial performance. Which means the patient experience mattered the most to the hospital, to the government hospital. So if government hospital provide a better patient experience, they're more likely to get better funding and better reimbursement from the government. So here in the summary, the hospital time made a difference, had an effect, moderating effect. Next slide, please. So there are 5 interesting descriptive findings from descriptive analysis. Overall, patient experience improved from 2009 to 2012. Kind of coincide with the ACA, which passed in 2010. The for-profit and the government hospitals consistently outperformed nonprofit hospitals in patient experience. Smaller hospitals consistently outperformed large hospitals. I hope someone will help me explain why. Probably in my follow-up studies. And the fourth one, same thing. I'm still asking why. Rural hospitals consistently outperformed urban hospitals. And operating profit margin and cash flow margin were the 2 consistently significant indicators of a hospital financial performance. Next slide, please. So from the hypothesis testing, the 3 findings are kind of worth pointing out. The first finding is patient experience was associated with hospital financial performance. So overall, hospitals that did better in providing patient experience also did better financially. Second, hospital type moderated the relationship between patient experience and hospital financial performance when the indicator is operating profit margin and the cash flow margin. Third, the government hospital type demonstrate the greatest moderating effect on the relationship between patient experience and hospital performance. Again, when the indicator is operating profit margin and the cash flow margin. Next slide, please. So some implications for practitioners. The legislative actions and industry advocacy may be effective to help improve patient experience. The fact that smaller hospitals with fewer resources that consistently outperform large hospitals and smaller rural hospitals, again, with fewer resources, consistently outperformed large urban hospitals, may explain the employee engagement, patient engagement are important. It also indicates that develop a hospital employee competencies in quality leadership and patient-centered care. Like I mentioned at the beginning, that Dr. Kathy Adler did a residential learning institute on patient-centered care and patient-centered leadership. Maybe that's important. And also, for-profit, nonprofit, and government hospitals may behave differently. For example, because their mission is different, and for-profit hospitals may choose to treat certain cases and not treat certain cases, where the government hospitals may not have choice, and they choose all the patients. So the last point being the government hospitals may sacrifice their operating revenue and may even incur additional costs to treat certain difficult cases. So next slide, please. And the study findings may also inform practitioners. So for example, the healthcare legislators and policymakers and different level, healthcare stakeholders in health systems and healthcare designers, planners, and hospital levels, hospital board members, executive leaders. I see some of our DHA students there, and they're executives in the hospitals. So I'd like to discuss with you guys and what you think of this, the findings. All stakeholders involved in direct-to-patient care. Next slide, please. So made a few recommendations, and for example, make some recommendation to board engagement. For example, the board may play a leadership role in leading the healthcare organization, the hospital, to establish the mission that very inclusive in patient-centered care, improving patient experience. Next slide. And next recommendation is about leadership engagement. So for example, leadership development, leadership competency development, allocate resources, succession planning, so on and so forth. Next slide, please. And employee engagement. Some industry advocates believe we should have 4 aims. The 4th aim should be improve employee engagement. If you don't have a happy employee, probably it's hard to have happy patients. So the 3rd recommendation is about employee engagement. Next slide, please. So lastly, we recommend patient engagement. So for example, provide education material for patients, even provide the partner with patients and their families, develop the materials maybe in different language. We're very diverse. The country was a very diverse population. Studies show that patients who do not speak English well, the medical error are greater involve these patients. So maybe patient education using their language will help. So it's part of the patient engagement. Next slide, please. So this slide shows the limitation of study. Obviously the main limitation is the secondary data. hospital compare data, self-reported by the hospital. But it's administered by Press Ganey, which is third party, so that provides some objectivity. Nevertheless, the information reported by the hospital. And then the HICRIS, which is the financial performance data, again, it's self-reported by hospitals. Yeah, you know, hospitals go through audits and the financial statements go through audits, and they need to prepare the financial statements based on GAAP. But again, I cannot verify the accuracy of the information self-reported by the hospitals. So these are really the main the main limitations. And the other is for the indicators of financial performance. 5 indicators emerged based on literature review. So in the future, maybe some may include some other indicators of financial performance. Next slide, please. So in summary, put it all together, overall, hospitals, if they do well in providing patient experience, they can do well financially. Patient experience is an emerging field of research interest. Some institutions like Rush University already started offering a course in patient experience. They already did last semester. They used a practitioner as an instructor. They're actually developing the further developing the course. They started they proposed a workshop at this year's AUPHA conference in June. So we may see some development in offering some courses, further development in offering courses is related to patient experience. But what we can see, patient experience is multidimensional. It involves more than just patient experience itself. It involves board, which is strategy. It involves leadership. It involves employee and the patient and so on. Next slide, please. So I just wanted to thank my committee because the study was my dissertation. So Dr. Stavros and Nicole and Mikovich are on my committee. And Dr. Hueda and Ms. Murray, the two provided there with Ohio State University. And Ohio State University, as you know, the family medicine has a huge grant. They were able to get various databases. They have very complete database that are maintained by CMS. And so I was able to work with them and get the data. The data that you get directly from a CMS website, in theory, you can download from their CMS website directly. In reality, it's very, very difficult for you to make use of the data download directly from CMS website. So it's, you know, it definitely takes some work to have really good understanding of the database. So that was the part, really consuming part, is really understand the data, what it means, and also time-consuming part is data management. The most fun part is data analysis. Next slide, please. So here, as you can see, it's very interesting. The first picture is the grand piano at the lobby of Mayo Clinic's Rochester facility, Rochester, Minnesota facility. The dog is a therapy dog. That picture, I took that picture in a Harry Ford Hospital near my home. On the right, on the top is again, you see the greenhouse. That's a greenhouse that Henry Ford Hospital grows the organic vegetables and herbs they use in the cafeteria. So patients and the families and the staff can all go to that cafeteria. So the lower one with the garden is one of the facilities of the Mayo Clinic. As part of this study, I visited these hospitals and really asked for permission whether I can take pictures and just stay there and observe. And it's very interesting for me. Well, thank you again for your participation in this discussion. See if you have any questions. I'd be happy to take questions. And then if you have follow-up questions, again, on the first slide of this presentation, you can see my email address, and feel free to email me for any follow-up questions. Thanks again.
All right, thank you very much, Lihua. Does anybody have any questions? You can use either the chat or the Q&A. And if anybody wants to ask a question in person, you can ask me to bump you up in the chat, and I can bump you up so that you can ask your question audio. Okay. We're getting a few thank yous. Kathy Thomas asked, she says, more of a comment. I think patient experience data feedback will be very useful for hospitals to use in marketing techniques as well.
Yes, Kathy. A lot of the hospitals now developing their marketing strategy based on their patient experience data. And they also use their patient experience data to find where they need to improve. For example, one hospital in Michigan found their patient experience measures are very high, among the top 10%. However, the two areas that's still low is patient complaint. The area is kind of noisy, again, it takes the board and takes the leadership, and so they decided to invest. They renovated patient room, used the insulation to help reduce the noise level, and so it was investment. But after that, that particular measure, the score was improved.
And Heidi Rothschild asks, has a survey ever been done to ask patients what is most important to them during their hospital experience?
That's an interesting question. Not in the current HCAHPS. But again, HCAHPS is just the first nationally standardized survey. Individual hospitals had been doing their surveys way before the HCAHPS. So it would be very interesting to look into that, Heidi. I don't have an answer to that question right now.
Okay. Do we have any other questions? Okay, Lihua. Well, I don't think we're getting any other questions coming in. Oh, wait. Johnny Vo says patient rounding is one tool hospitals can use to gather patient experience data.
Thank you. Would that comment?
I think so.
Yeah, okay.
And then Jason Studley asks, how would you suggest reporting bodies such as care checks, health grades, HCAHPS, health stream, etc., standardize patient satisfaction questionnaires?
Well, Jason, that's a good question. To me, I find the we probably will now standardize among those individual survey instruments may improve individual. So, for example, the HCAHPS. One thing we can do is develop improve the HCAHPS survey instrument by collecting the input from patients and their family members. So also maybe the HCAHPS can be administered to patients who may not actually had an overnight stay. So for example, I had a recent experience with my husband had a surgery. And so, I waited outside the surgery room, in the waiting room for 8 hours. Obviously I was just sitting there, observe the patient experience and their family member experience, and you may use our time. But I did, in our case, we don't get the survey instrument. So I think we can improve the existing instrument, may expand. And especially given the cost cutting, more and more surgeries. Like my husband's surgery was major surgery, but it was outpatient. So right now the HCAHPS only administered to patients who had overnight stays. What do you think, Jason?
Yeah. While we're waiting for Jason to respond, Heidi says patient satisfaction is often based on the bedside manner of the doctor and not the medical care, as it is hard for a layperson to judge the quality of medical care. And she wants to know what your thoughts on that are.
Well, that's a really good question, Heidi. For example, some nurses will tell you they got bad score because they told a patient that the patient had just had a heart surgery who wanted to have a Big Mac. And so the nurse said, no, you cannot have Big Mac. It's not good for you. So she got marked down on a nurse communication. So these are very, very interesting anecdotes that I collected and as part of my future studies. Really look into these factors. It's so complex and multidimensional. So when you say a patient may, mark the doc and a nurse, down in communication because the patient didn't get what he or she wanted,
Interesting. Jason responded, excellent response. Fix the base tool and we can move towards standardized responses. I would support a set of questions regionally based from one accrediting body.
I agree, Jason. So it looks like we have some follow-up discussions. For those of you interested in this area, feel free to email me and I'm happy to discuss further.
Okay. right. Well, as Lihua said, if you do have any further questions, feel free to email her. I really appreciate the fact that we did get some responsiveness from our audience today. And I thank you very much, Lihua, for a very informative presentation.
Thank you all. Thank you for your participation today.
Okay, Lihua, I'm going to go ahead and hit end.
Okay. Thank you.
Okay, thank you. Bye-bye.